So welcome back, everybody, to the second installment of the 5th Annual Montreal Oscillometry Summer Seminar. We're going to be sticking strictly to the schedule for a change. And with that, I will show 2 more slides and then pass the podium to Kate. Additional statistics would be 128 participants from last podcast, so that's great. And we've already updated the website at the REG over in the UK. So last week's session is ready for viewing if anybody missed it or wants to share it. So with that, I'll stop sharing my screen. And it's a great pleasure to introduce to you somebody who I've not yet met, but was contacted me saying that she thought she would like to share her work with us. And I said, welcome. So please, Kate Smith from the University of Colorado, take the podium and we're going to listen to your talk with interest.
Great. Thank you. Can everyone hear me?
Well,
great. So thank you so much for this opportunity to speak. I'm a little new to oscillometry, but I've been working with these measurements over the past 3 years and implementing in various clinical research settings involving children with asthma and asthma exacerbations, Down syndrome, and just recently toddlers who are patients in our air digestive clinic. And so my goal
could I ask you to turn on your video because we have your picture, but if your camera works, it would be nice to have the live image.
There you go.
Thanks.
Okay. So my goal in measuring lung function with oscillometry in these kind of sometimes challenging settings is to further establish and promote its utility in pediatric clinical care for diagnostic purposes and monitoring responses to treatment, particularly in these patient populations where other measures of lung function just aren't feasible. So our motivation for studying lung function in children with Down syndrome stems from the statistic that respiratory disease and pneumonia are leading causes of morbidity and mortality in people with Down syndrome, and the public health burden as well as the impact on caregiver quality of life related to respiratory illness is significant, with over half of hospital admissions in this population being for respiratory reasons, with respiratory illness being the most common cause of hospitalization in children 3 and younger, and length of stay is generally 2 to 3 times longer compared to people without Down syndrome. So there are a number of respiratory comorbidities in Down syndrome, including airway structure anomalies like laryngomalacia, tracheomalacia, subglottic stenosis, dysphagia with aspiration that's often happening silently. And these conditions have been associated with higher rates of recurrent lower respiratory tract infections and pneumonia. So in addition to lower respiratory tract infections in general, RSV bronchiolitis in particular has been found to be more common in children with Down syndrome than those without. Recurrent wheeze is very common as well. And interestingly, a couple studies have shown that neither prior RSV bronchiolitis nor asthma or atopy were significant contributors to occurrence of wheeze, which is in contrast to children without Down syndrome. So other comorbidities, at least half of our patient population at Children's Colorado have a diagnosis of obstructive sleep apnea, and pulmonary hypertension is somewhat common in young children as well. So these respiratory problems certainly affect health over the lifespan, increase susceptibility to recurrent infections that contribute to poor lung function. And while we do have, very sophisticated tools like bronchoscopy, swallow studies, CT scans to aid in the care, the use of non-invasive lung function testing to screen and monitor respiratory health and responses to treatments has been very limited. Spirometry is challenging in children in general and is made more difficult to accomplish due to the developmental delays and hypotonia common in Down syndrome. And so as a result, we just don't know a lot about lung function in this population and how it compares to people without Down syndrome. So as I'm sure you all agree, oscillometry is an excellent tool to employ in the clinical management, as well as the study of respiratory health in this population. And as far as I know, there has been one prior publication just demonstrating efficacy of impulse oscillometry in a cohort of children and adults from Mexico City. And now I'll present results from the second using airwave oscillometry, which was just accepted for publication by and the study was started by one of our former pulmonary fellows, Monica Bielkine, and it's continuing with Dr. DeBoer at Children's Colorado. So in our work, we have shown that obtaining lung function measurements with airwave oscillometry is certainly feasible with a fairly high rate of success. We've had 40 out of 50 kids able to complete successful oscillometry measurements. And in the cohort describing here, half are male, half are female. The median age was around 10 years with an age range of 4 to 17. And so the height and weight spans are large. So we do show Z-scores using published reference population. So for relevant comorbidities, most have congenital heart defect as well as a diagnosis of OSA. Over half of the parents reported previous wheezing or whistling in the chest at some point in the past, yet very few had been diagnosed with asthma. Almost half were born at a gestational age of 36 weeks or less, but I'll note that only 3 of these were less than 34 weeks, and a third had airway structure anomaly noted from bronchoscopy, and a quarter had a swelling study showing aspiration. So for our oscillometry results, we did not see abnormal trends in baseline airway resistance at 5 Hertz compared to the reference population, but we did observe a bronchodilator response of at least 20% decrease in low frequency resistance after albuterol in 20 of the 36 children with pre-post tests, with a median decrease in resistance of 22%. Baseline outcomes were most notable for pretty variable and abnormal reactants, X5, with the median Z-score of the cohort below the lower limit of normal at negative 1.8. So X5 also improved with albuterol with median increase of 26% and 25 out of 36 showing improvement of at least 20%. And 4 still had X5 below the lower limit of normal even after albuterol. And for reference, I'm not showing AX here, but it was also improved with a median decrease in value of 38%. So these responses I know don't quite meet the cutoff threshold suggested in the latest technical standards, but I think it will be worthy investigation to establish the clinically relevant thresholds within this population. So in further investigation of this kind of low reactance in our cohort, we looked at the difference between expiratory and inspiratory reactance values among those with normal and abnormal reactance at baseline. And this box plot shows the absolute difference between the expiratory and inspiratory reactance values, with negative values indicating that the expiratory reactance is more negative than the inspiratory reactance, and positive values indicate the expiratory reactance is less negative than inspiratory. So children with abnormal baseline reactance tended to have a greater difference between their expiratory and inspiratory values, with more negative reactance during expiration compared to inspiration. And this was less pronounced in those with normal reactance at baseline. And so one hypothesis for this is that a potentially low airway tone, which is somewhat common in this population, may be leading to early closing volumes during expiration. And so I mentioned that we really need better objective measurements of lung function to provide better care for children with Down syndrome. So I'm showing an example of how we may be able to assess lung function in relation to comorbidities and monitor the responses to treatment. So only 6 out of 40 children in our cohort had not been diagnosed with obstructive sleep apnea from their sleep study, and stratifying this cohort by degree of OSA severity based on their obstructive apnea hypopnea index is none, mild, moderate, or severe. We see trends of increasing resistance and decreasing reactance, indicating worse baseline lung function. with level of OSA severity. And so we expect that resistance would increase with what we presume is higher levels of airway obstruction, but the corresponding decline in reactants might be less expected, although this could be reflecting heterogeneities in airway obstruction. So in the mild OSA group, which is kind of the largest in our cohort based on their OAHI score, and shows quite a great variability in airway resistance. Within this group, if we stratify by those who have for some reason been prescribed an inhaled corticosteroid versus not, we do see a small trend. I do acknowledge the number of data points is small, that those who were being treated for airway inflammation have lower airway resistance. And this highlights how we can use oscillometry in monitoring our responses to treatments in this population. So in summary, recurrent lower respiratory tract infections and other respiratory comorbidities are common and often more prevalent in children with Down syndrome, which indicates a real need for these non-invasive measures of lung function, and oscillometry is certainly a useful tool for this, and is successful to implement in both research and the clinical context. And compared to what we have for available reference equations, airway resistance was normal and reactance was abnormal in our cohort. To speak more about that, low reactance is typically seen in conditions with decreased compliance, like asthma, but in our patients, we don't really see the increases in airway resistance. And we didn't have specific diagnoses related to restrictive lung physiology in this cohort. The decreased compliance may be related to alveolar simplification or abnormal lung structure contributing to heterogeneities in the system. There's also underlying cardiopulmonary comorbidities, inflammatory processes, or low airway tone. And so one possible explanation for the lower reactance during expiration in some children could be related to low airway tone with early closing volumes during exhalation. This has, I think, been described in adults with expiratory dynamic airway collapse. Only a small number of our current cohort had bronchoscopy results confirming a tracheobronchomalacia, but there is a high rate of this in the population in general. So it will be an area of future investigation. And finally, I showed some evidence that we can use oscillometry to detect differences in lung function related to OSA severity, as well in responses to treatments. And with that, acknowledge all of our collaborators who've been working on this study and our funding sources.
Well, Kate, thank you very much for a great talk and also respecting the time limits. I'm going to turn the floor over next to Sam Bayat from the University of Grenoble. Sam is going to lead off the discussion for Kate's talk, and then he himself will give a talk for which Kate will be the discussant. So Sam, over to you.
So thank you, Ron. Well, Kate, thanks very much for this beautiful presentation. Very interesting study. I'll just make a short comment that this is a at-risk population and very difficult to get traditional lung function measurements in this population. So the fact that airway oscillometry is feasible in children with Down syndrome is definitely significant for the respiratory health. So are there any questions from the audience? Please turn on your microphone or write in the chat.
Hi, Larry Lance here from Montreal. Kate, thank you very much. That was really very interesting to see and great collection of data. I work in pediatrics, so and we do see a fair number of Downs, and I totally agree with you with everything you said. A couple of things. I was intrigued that the resistance was worse in those with more OSA, and even though R5 is supposed to be more small airways, what do you think? Could there be a contribution of upper airway obstruction with the large tongue, etc., contributing to some of those R5 measurements?
I do think that this is a very small number. So it's hard to like do statistical comparisons, but I think that there's some of the central airway obstruction physiology may contribute it to that increase, but it's also noted we do see decreases in reactants as well. So it definitely warrants further data collection for this.
So in terms of the reactants, I just wonder about truncal tone being a contributor to small airway collapse. We know some of the downs can be particularly sort of floppy. They might not have the same chest wall tone, and so they might be working. Their working volume might be at a smaller lung volume than somebody else.
Yeah, I agree.
Zoltan, please.
Just trying to propagate the idea originating from Stuart Gottfried, who advised us to measure obese hypoventilation syndrome patients in supine position. So this might, in part, be relevant to this population because the majority has some obstructive sleep apnea, which is associated more with the supine position than with the sitting. So I know the collaboration is not very easy, but 40 out of 50 is not too bad. So what if you tried that?
So I'm not familiar with that literature about the supine position, but I think that we could implement that as well.
It's a portable machine.
So thanks. We have a question on the chat from Laura Gochko from Mexico, and she asked whether you analyzed the resistance at 20 hertz, R20, or reactance at 20 hertz.
Yes, so we did look at R20. I didn't show that there. I don't think that it was much different than, comparison to the reference equations. We didn't see anything remarkable there. And then the AX I didn't show. One point about the reference equations we're using that were collected with iOS, just because of the age and height span that we have, there aren't those for AX, so that's not shown here.
And we have a question from Changwei Chao on the chat. Was there a difference in the measurements in the subset with congenital heart disease?
So 31 out of the 40 had congenital heart disease. So I think that would be difficult to tell.
Ron.
Yeah, looking at the distribution of the reactants data to a bronchodilator, it seemed that there might be a bimodal distribution on the reactants to bronchodilation, which wasn't apparent on the resistance. And wanted to know, was there anything clinically that distinguished those who had a greater bronchodilator response on their reactants?
I can't answer that at the moment,
okay.
But that's a great point and something that we should definitely look at.
So I think Jeff Maxim has a question. Jeff?
Yes, very nice. I guess, did you look at the frequency dependence of resistance at all? And the reason I'm asking is that you found normal values for the patients with, for the subjects with resistance, but abnormal with reactance. And some of the evidence with the bronchodilator might be recruitment of airways in the periphery. And reactants can be more sensitive to that than resistance at 5 hertz. And sometimes you get confirmation that that's what's happening, looking at the frequency dependence of resistance, but still reactance, because it doesn't have to sit on top of a large central airway resistance, it can be more sensitive in cases. And I'm wondering if that's what you've got in this population.
Yeah, that's a great point. That I think we should definitely look at further in terms of understanding this a little better. So thank you for that.
Sam, in the interest of time, how about you field one more question and then get on with your own presentation?
Yeah, great. That's we have time for one more question.
Maybe this is Wayne Morgan, maybe from Tucson, Arizona. A brief comment. Do you think the closing capacity could also be due to alveolar simplification, as is seen in Down syndrome? That they might have less recoil, and then tied together with Larry's comment about thoracic compliance being increased, that maybe those two things could lead them to be more likely to close those airways off.
Yes, yeah, we have considered the alveolar simplification and the heterogeneities that's going to cause. And
yeah, it would be interesting to do some quantitative HRCTs and relate them to what you see with the lung function and get structure function correlation.
Yeah, that would be great.
So thanks very much. I think our time is up for the discussion. Thank you. And Ron?
So, well, over to you, Sam. Sam, who is still from Grenoble, France, will be giving the next talk entitled Association Between Oscillometry Parameters and Respiratory Outcomes in 3-year-old Children from the CEPAGES cohort. And Kate will now exchange hats with Sam and take over the discussant role. So please, both of you, take it away.
So thank you very much. Again, pleasure to be here and have the opportunity to present these data. So the respiratory symptoms are highly prevalent in infants and young children. For example, approximately 30% of children in the general population will present at least one episode of wheezing before the age of 3 years. And of these wheezers, about a third will go on to develop persistent asthma after the age of 3 years. So epidemiological studies have shown that early lung development is an important determinant of long-term lung function and of general health, of course. In other words, the origins of disease can be frequently traced back to the fetal period and infancy and early childhood when the lung is still developing. And this is often cited as the concept of developmental origins of health and disease. And to address the question of what are the determinants of early lung function impairment, birth cohort studies are important to improve our understanding of these determinants. However, many of these birth cohorts measure lung function later on at school age or adolescence or even adulthood. So there are few general population studies in preschoolers, and this is obviously because of the difficulty of getting good quality, mainly spirometry data in this population. So with the thought that airwave oscillometry data are, let's say, easier to acquire, require less cooperation from young children. So the goal of this study was to assess the relation between airway oscillometry parameters and history of respiratory symptoms and illness in 3-year-old children. And the hypothesis being that increases in oscillatory resistance and frequency dependence of resistance and also reactance will be associated with a history of respiratory symptoms and illness already at 3 years of age, which means sooner than what is usually investigated in this population. So the recruited children were part of the CEPAGES couple-child cohort. So briefly, this cohort aims at assessing the effect of outdoor and indoor air pollution and environmental exposures. And these include particles, nitrous oxide, volatile organic compounds, etc. And these are actively sampled using a device that's carried for about a week by the mothers during their pregnancy. So aiming at quantifying in utero exposure. Also, a number of biological samples are collected in the mothers and early on in the infants. And the goal is to look at the outcomes of respiratory health, effects on growth, and also on neurodevelopment. So this is a single center cohort, and all the mothers and infants were recruited in the Grenoble area. And the appropriate, of course, ERB approval was obtained and the couples gave informed consent. So respiratory health was assessed repeatedly using a modified ISAC questionnaire. And the questionnaire was administered at 2 months and then each year at 1 year, 2 years, and 3 years. and particularly history of physician-diagnosed asthma, wheezing, bronchitis, and bronchiolitis were assessed over the past 12 months at each time point, or since birth for the first questionnaire. So the other point is that FRC and lung clearance index were measured at 6 weeks by multiple breath washout. Of course, I'm not presenting those data here. And at 3 years, respiratory impedance was measured using the TremoFlow device. And again, and also ADAPI was assessed by skin prick tests. So the data were analyzed by simple linear regression for the univariable analysis of the oscillometry indices with the respiratory illness and symptoms, and also the subject characteristics. And the multiple regression models were adjusted for age, sex, and height. And also a sensitivity analysis was performed by excluding, on one hand, children who performed only 2 acceptable tests versus 3 or more, and children who had positive skin prick tests. So initially 471 couple-child trios were enrolled. And of these, 384 attended the 3-year visit, and 320 children performed airway oscillometry. And of these, 306 had reproducible and acceptable measurements. So this slide shows the subject characteristics. 54% were male. The mean age was 37.5 months, which is slightly above 3 years. 95.5 centimeters was the average height and weight. And passive tobacco smoke was present in 20% approximately of the children. Level of parental education was high, almost 75%. Also, the majority of children were breastfed. Only 10% had a gestational age less than 37 weeks, and about 11% had a positive skin prick test. So as far as the respiratory history, about 14% of these children had a diagnosis of actually ever asthma, according to the parents, but physician-diagnosed asthma was present in about 12%. About 33.4% had, 0.8% had wheezing, and almost 38% had bronchiolitis ever, or bronchitis ever was present in 22% of these children. So regarding the oscillometry indices, the mean resistance at 7 Hertz was 11.8. The R7Z score, according to equations by Shackleton, was 0.55. We did measure the frequency resistance or dependence of resistance. Reactance at 7 Hertz was -4, or the Z score was 0.6. And also AX was measured in these children. So regarding the univariable analysis, only R7 -19 depended on sex. R7, X7, and AX depended on height and weight, and X7 and AX were associated with passive tobacco smoke exposure. So the multiple regression analysis, which was adjusted for age, height, and sex, showed us actually positive effects with R7. As you can see, the effects are, in terms of the effect size, are present for physician-diagnosed asthma, wheezing, bronchiolitis, and bronchitis, which is lower respiratory tract infections on R7. But in terms of the p-value, only the lower respiratory tract infections were actually significant. This was true also for AX. So as you can see, wheezing, bronchiolitis, and bronchitis were significantly associated with AX. And again, lower respiratory tract infections were significantly associated with the frequency dependence of resistance. So also, when you remove the children who had only 2 reproducible oscillometry measurements, there were 51 of these, So these associations remained. And also when you remove the children with positive skin prick tests. So early life viral lower respiratory tract infections are well known to affect lung function later in life. And these are more often due to rhinovirus and respiratory syncytial virus. The earliest assessment of lung function has usually been performed again at 5 to 6 years in birth cohort studies. However, in this study, early lower respiratory tract infection was associated with lower lung function already at 3 years. But I should say that interpretation of this finding is complex because there are also other studies that show that early decreased lung function during infancy increases the risk for subsequent lower respiratory tract infection and wheezing illness. So again, it's hard to draw a causal relationship, but there's definitely an association. We do conclude that oscillometry is a useful method for epidemiological studies on respiratory health in preschool age children. And the future perspective of this cohort is to assess the effect of the various environmental pollutants, including in utero, on lung function and the interaction with lower respiratory tract infections and wheezing. So with that, I would like to end my talk, which is 10 minutes, and I'd be happy to answer any questions.
Sam, thank you very much for a superb talk and showing me how my patients might have looked once upon a time, well before they met me. And Kate, I'm looking forward to you taking over the screen and animating the discussion.
Great, thank you. That was a great talk, Sam. And I think it really highlights the importance of earlier lung function measurements and really understanding how these poor lung functions are happening already at the age of 3 and what types of environmental or prenatal factors are contributing and how we might intervene. I will first ask, does anyone have questions for Sam?
Yeah, this is Charlie Irvin. Nice talk. I assume the kids are going to have more traditional measurements of lung function assessed. Have you gotten around to doing that yet?
Actually, we just finished the measurements in these 3-year-olds. So I assume that on the next round of measurements, when they're at school age, definitely they'll have spirometry.
I thought they were already at school age. I'm sorry about that. In regards to the cigarette smoke, could you? It kind of went by kind of quickly. What was the effect that you saw of environmental tobacco smoke on oscillometry?
So the effect was that the kids who were exposed to passive tobacco smoke tended to have more negative reactance at 7 hertz and a larger AX.
Okay.
And I think there are other studies. I saw a study with iOS that actually Kate pointed to me. Thank you, Kate. Where there's also an association between AX measured with impulse oscillometry and in utero smoking, which is slightly different here. This is passive smoking after birth. At some point, we'll have the in utero smoking data, which is based on cotinine measurements in the mothers, but I don't have that data yet.
Well, because as you know, I mean, cigarette smoke exposure is the one absolutely known factor to cause asthma in kids. So finding that relationship with oscillometry, I think is really an exciting result. Thank you.
Thank you.
There's one question from the chat. Were the asthmatics receiving inhaled corticosteroids?
Oh, that's a good question. Actually, when we measured the children, none had ongoing asthma. And I don't know if, I can't positively say that none of them were on corticosteroids. That's a good question. But they had history of physician diagnosed asthma. To my knowledge, they weren't actively asthmatic and on corticosteroids. But that's definitely something to to check.
Yeah, it could confound the results so that you tended towards a negative, towards the null. Although a lot of what you could be seeing really are the low lung functions that we see in the kids who, to use the old Tucson term, are transient wheezers, particularly with John Hanrahan's data and then others since with smoking in utero, as Charlie Irvin was saying. They have forced expiratory flows that are in Hanrahan's study, 50% of the babies not exposed to smoke in utero. And in subsequent studies, the impact effect size is more 20 to 30%, but the cigarette dose is almost half in more recent studies. So that would be interesting to look at if you see any dose response relationships to the amount of smoking in utero within that group.
Thanks for the tip. Thank you very much.
So there's two people with their hands up. I think Cindy, you raised your hand first. Do you want to ask a question?
Thanks, Kate, and thanks, Sam. Good to see you. Can you hear me?
Yes.
Great. Okay. I have a couple hopefully quick questions. It's the first was it's interesting that early LRTI was more significantly associated than doctor diagnosed asthma for oscillometry parameters, which maybe highlights how unreliable doctor diagnosed asthma is. But did you look at multivariable analyses? I'm sorry if I missed it.
Oh, I did. Yeah, I thought I showed those data. So
Okay.
let me show it again.
Well, while you're doing that, sorry.
So the multivariable was here. So this was actually the multivariable.
Right. So all those had already taken into account. I guess I was puzzled also because the R7 with bronchitis, that doesn't look like it was significant to me, but so hence I was trying to figure out whether it was a difference between univariable and multivariable.
Yeah, well, here you're right. I mean, in terms of the p-value, it's not significant, the bronchitis with R7, right? And also it's also the case with physician diagnosed asthma, but as you can see, the betas show that definitely there's something there. And I think the fact that the p-value doesn't really reach significance is a question of statistical power.
Okay. Yeah.
And this is also true when you take out the 50 kids, for example, who have positive skin prick tests, you still see the same effect size, but because of the confidence intervals, you lose the statistical significance.
Yeah, I guess. I mean, I guess I didn't see that much of a difference between the bronchitis and, say, the physician diagnosed asthma for the R7 variable. Just looking at those plots per se.
It doesn't look that different. Yeah, I agree.
And I guess my second quick question was, it's interesting that AX, which usually tracks with X, is significantly related, as well as R7 minus 19. And I wonder whether then, and maybe others might have more to say about it, whether this reflects more that there's heterogeneity rather than a phenomenon of lung volume. And so I also wondered whether you use Z-scores or raw values in looking at these associations.
Sorry, I didn't get the final part of your question.
Did you use Z-scores or raw values that would help account?
Oh, yeah. Yeah, that's a great question. So we did use Z-scores for X7 and R7. We didn't use Z-score for AX simply because we referred to Shackleton reference values, and we didn't have equations for AX in that data set. Of course, we could use Calogero, but then the choice of Shackleton was based on closer technical properties of the measurement. But so we did use also Z-scores for R7 and X7, and again, the effect sizes are very, very similar.
They were similar. Okay, yeah, because that would have taken away the possible effect of just lung volume size per se on your findings.
You mean volume dependence of the?
Yeah.
Okay, Kate, maybe you could take one more question, and we'll move on so that we can let Jeff and Zoli have their presentations as well.
Great, Leonard, quick question.
Okay, Actually, my first question was the same as Cindy had. So, but I maybe a comment here about the AX and the lack of effect on X7. Could that just be inertance being at play here, so that the dimensions of the airway system actually changed? And that is what's driving the shift of resonance frequency. I don't know, Jeff Maxim actually might have some comments on this.
Well, that's a good thought. You know, my gut feeling would be that AX, the fact that it's perhaps slightly more sensitive, could be just the fact that you're integrating several frequencies instead of one. Of course, whether or not there's a significant contribution of inertance is very hard to tell based on these data.
Of course, yes. No, it is pure speculation. All right. Thank you very much for a nice talk.
Thanks.
Okay, great. So Sam, you'll unshare your screen.
Thank you
And
very
while
much.
Sam is doing that, thank you, Kate, for leading off that discussion on Sam's talk. And Sam, thank you for that talk. Jeff Maxim from Dalhousie is going to be talking about the frequency dependence of resistance, nonlinearities in tissue, and heterogeneities in chronic lung allograft dysfunction. And Zoli Antosh, who needs no introduction, of course, will be the discussant, and then they'll change roles, and I'll let you guys do the introductions to the Zoli's talk, and I look forward to both talks and discussions. Please take it away, Jeff.
Great, thanks, Ron. Is my screen fine for everyone? Okay,
Right here.
great. All right, so yes, I'm going to talk about frequency dependence of resistance and a particular source that we've been investigating recently. So here's an example of frequency dependence of resistance measured in healthy subjects by actually Zoltan Hantosh and colleagues in 1986. And that's the respiratory resistance of the patients, and then the tissue resistance separated out after the airways were removed. And you can see it's frequency dependence, but the frequency range is incredibly low. This is 5 Hertz, so this is below the normal oscillometry range. And this frequency dependence is usually ascribed to viscoelastic properties of the lung tissue. And a very good model that includes this frequency dependence that Zoli developed is known as the constant phase model in the box here. And you can attach an airway resistance to this model and account for this step change in resistance simply by the added resistance proximal to the tissues. Now, the interesting feature of this is that you're separating out a tissue component and an elastic component, and it's all over omega to a constant called alpha, and which means it inherently incorporates a frequency-dependent tissue resistance, and also the H is also frequency dependence as well. Another example of this from patients at very low frequencies taken during mechanical ventilation, or I think it was optimal ventilator waveform in 97 from Kazga et al. Shows this frequency dependence as well. Again, very much at low frequencies in healthy subjects. And on the right here is a model that Hantosh published that shows how this term here can account for this frequency dependence observed. Now, the frequency dependence shifts in disease. So if I have asthma, and here we have Cavalcanti in 2006, healthy subjects, we don't see any frequency dependence. And imagine this curve going below 4, 5, and then scooping up according to this graph. So maybe that's what's happening in these healthy subjects, but for whatever reason, the frequency dependence is increasing as we go to increase in severity. And it's thought to be due to the heterogeneity in the small airways that's increasing R5, here at 4, above R20. So R5 minus R20 is thought to be heterogeneity in the small airways. Now, it can be heterogeneity at any level. Otis showed in Mead in 1956 that if I just make the left half of the lung different from the right half of the lung, changing R1 relative to R2, I can create frequency dependence. And if I want, using multiple branches, I can fine-tune this frequency dependence to match any data that I want. Of course, Jason Bates and Simulowski showed that it doesn't matter the structure that I create my model in behind the scenes. Now, this might be more realistic for asthma and small airways heterogeneity, where all the little airways might have different resistances. But the Mead model, which is the series model, can also account for this. Probably some combination is actually a realistic picture of what's happening in the lung. And Charlie Irvin showed that I can actually affect this frequency dependence if I just breathe a different gas. If I breathe helium-oxygen mixtures, this tended to increase the frequency dependence of resistance in response to histamine infusion. So this is a graph where there's air on this side. Control subjects, these are different subjects, 6 responders, he termed them, from a mixed group of healthy and mild asthma. Probably people from around the lab. And they infused histamine, and they all had slightly different responses. More consistent responses when breathing helium-oxygen, but you can see that the trend here is a 32% change from control to histamine versus a 22% change with helium. And it was thought to be due to the increased viscosity in the peripheral airways. So I'm not changing structure, presumably. I'm only changing the gas that's in the structure. Now, on top of those sources of heterogeneity, what I'm going to be talking about is time-varying elastic properties. So another source that we've investigated, published in 2019, is that if the elastic properties of the lung are varying in time, you might see frequency dependence and resistance. Now, that's a crazy idea. It's the elastic properties that are varying, but it's showing up in the frequency dependence of resistance. How can that be? Well, first I'm showing this graph of DILACA, which is in COPD patients. Well, this is a single patient showing how reactance is changing quite a bit from -2 to -8 centimeters of water per liter per second, and changing in time. So elastic properties do change in time as we measure them with forced oscillation, and a potential measurement mechanism for how frequency dependence might be related to this was put forward by Lofty-Zada in 1950. Now, he didn't do anything in physiology or in lung physiology. He was doing this in electrical networks. Here he is here, but he's an eminent electrical engineer, and he did this analysis, but he also developed a Z transform, and he also developed fuzzy logic. Now, his analysis of variable networks probably wasn't used too much because there isn't a whole lot of variable capacitances in networks and electric circuits, but we have them. But it never made the transfer to respiratory physiology until, well, my student, Hamed Hanafi, started to look at it. Now, this is an equation, an expanded equation with zit impedance as a function of frequency like we normally have, but also as a function of time. And I'm not going to show you how this is derived. It's derived using Lofty-Zada's transform, but it shows that you can still have, if I have a resistance, an elastance, a simple model, but I vary this and I vary this. If I have those varying terms, how do they contribute? Well, it turns out that the resistance will have an additional term that's related to the rate of change of elastance divided by the frequency squared. So it's a frequency dependent additional term to the resistance. Oh boy. There's also a term that's added to the elastance, but it turns out the magnitudes of the variation in resistances tends to be so small that this disappears. If there is no variation, I still get my usual resistance and elastance. But if E varies, then you get this frequency dependent component. So where could it come from? It could come from the nonlinear tissue properties, which is something my student Anas Tahir has been investigating recently. So this is data from dog lung tissue strips. It's actually measurements that I did during my PhD, probably during my master's actually. So, and it shows the nonlinearity of lung tissue as you go over a very large stretch, all the way from 1 to doubling the stretch. If I have that behavior and I'm oscillating at some operating point, say at this high stretch, the stress will look like this. It just goes up and down as the stretch goes up and down. The slope of this will also change. So I can generate a time-varying elastic stiffness if I have significant amplitude over a nonlinear region of the stress-strain curve. Now, in order to model this correctly, we actually need to merge this static nonlinearity with the constant phase model, which actually was done by a few others. And here an equation that represents that. Stress as a function of strain with a nonlinearity, and the constant phase model that Zoltan Hantosh developed. If we do that, we get the same kind of behavior, except now we have a loop in our stress strain behavior. What happens with oscillatory strain at different operating points, just to demonstrate that it actually can occur. So if I only have the constant phase model, the stress strain relationship will look like this. The resistance versus frequency, because as I showed several slides ago, there is an element of frequency dependence of resistance that's inherent in the constant phase model, and that's the blue curve here. Okay, so you start out with some frequency dependence simply due to the viscoelastic properties ascribed to the lung tissue. However, because of this nonlinearity, you'll get this spread in behavior and resistance. For very low operating strains down here, I'll probably get less frequency dependence, whereas if I go up here, I'll have high frequency dependence of resistance. So what am I saying here? I'm saying that the frequency dependence can come if I'm going to stretch the lung tissues significantly, perhaps where there's a nonlinearity present, and it's over and above what you get from the constant phase model. We extended the idea to the whole lung. So using a common equation sometimes used to model the descending curve of the pressure volume relationship, the Salazar and Knowles equation, and taking some parameters from Gibson and Pride, so this is some older stuff, where they looked at the changes in pressure PV curves in different diseases. And so fibrosis is down here, normal is here, and emphysema is up here. And we picked some places arbitrarily where we might breathe. Granted, we didn't change anything else except the PV curve. So sometimes we get some very large pressure changes to achieve the same tidal volumes.
Jeff, you're coming up to the 10-minute mark.
Thanks very much. All right. So what does this produce? Well, it does produce time-varying stiffness if we track what's happening in time, dependent on this size of the nonlinearity. And we found that for the most extreme case, which was the fibrotic model, we got the largest frequency dependence. But it depended on where you were on the curve, and it's not necessarily where you would be in a non-modeling situation. Can we find this in measurements? So we've been also measuring patients with lung transplant, and some of them have very heterogeneous ventilation patterns. So in red, all the way to somewhere around blue, we have hot spots in ventilation and a highly heterogeneous section of the CT scan and the SPECT scan, whereas this one is more spread out. So in that patient with a high heterogeneity, they have also a high frequency dependence of resistance. They also have a high variation in the reactance at 10 Hertz, which we can use as a proxy potentially for their elastic properties. So we have both things happening, frequency dependence, but is this causing that, was our question. If it was, we should expect a correlation between the standard deviation of X10, that's this variation, and the frequency dependence of resistance, so R5 minus 19. And the models that I developed before, or showed you before, do predict a very tight relationship. However, the measurements didn't show this to be the case. Now that could be because we actually have a few patients with very low frequency dependence of resistance and a few patients with very low variation of standard deviation of resistance. So only a couple patients are actually useful here. And so the correlations might be poor because we need more subjects. But it's also possible that it's actually heterogeneity that's the governing mechanism for this case. There's definitely a lot of heterogeneity in these patients out here. And so that we believe is more likely the case, but it's preliminary data, so we don't know yet. So in conclusion, the frequency dependence of resistance can arise from viscoelastic properties, can arise from heterogeneity, and it can also arise from time-varying stiffness. And we believe it's more important for measurements at low frequencies because you actually need large amplitudes to demonstrate this well. You have to explore the nonlinearity in the pressure-volume relationship. And you don't really do that at very small amplitudes with forced oscillation. And in preliminary data, that may be the reason why it wasn't detectable in the oscillometry frequency range. But if you're ventilating an animal and measuring impedance, or if you're ventilating using the optimal ventilator waveform, which is rarely done, but can be done to measure low frequency mechanics, I imagine some of that frequency dependence in those studies was due to time varying stiffness. With that, I'd like to thank my student Anasta here, who did much of the work of the latter half of that, and some other students who helped contribute, and my collaborators. Thank you.
Jeff, thank you very much for a simply wonderful talk. You always remind me of how hard I or we clinicians have to skate to keep up with the modeling that you in the bioengineering world propose, but and equally I'm looking forward to Zoli leading off the discussion. So please, Zoli, take over the screen and let's hear your comments and your discussion.
Ron, please tell me how I can take over.
Well, if you want to share your screen, if Jeff stops sharing his screen, you should appear on the gallery. You can do the discussion from the gallery, and then we'll let you have your screen for your talk. So do you want to lead off a discussion for the next 5 minutes or so?
Yeah. Congratulations, Jeff. It's very exciting. So you had a very pessimistic conclusion at the end, but I think it can be easily overcome. So as you went through the possible sources of frequency dependence of resistance, if in patients we account for the upper airway shunt, which is a fundamental contributor to the frequency dependence of resistance, it will probably clean up the picture a little. And also in open chest animal experiments, we can also eliminate the chest wall contribution, which is not going along the same lines as the lung does. Approximately, or maybe at very low lung volumes it does, but further on in normal lung volumes and elevated lung volumes, chest wall would probably nicely contribute with a constant. So you would then refine your measurements by eliminating these things. I don't suggest, of course, a thoracotomy in every case, but in animal experiments, it would be really, really helpful. I don't know if Dave Kaska is around. I did not see him because he would be very helpful in commenting what large excursions, including low frequency signal components, would alter this picture. So back to the original things. The low frequency measurements are usually available in apneic situations, and that means that the amplitude of the oscillations is low. It doesn't need to be too elevated, and then these processes which you imply with the changing elastance of the lungs wouldn't be that apparent, but with larger excursions like the optimal ventilator waveform or the enhanced ventilator waveform, it would probably reveal maybe the linear subpart of the system, but I am not sure about that.
I agree. Those are good suggestions. In fact, Dave Kaska does still have that data. He did use the optimal ventilator waveform, so his is large amplitude oscillations. I wasn't aware that there's apneic data out there for small amplitude, so that would help sort it out. And I think your idea is about doing it open chest to remove other variables like variation in the chest wall elastance as we're breathing from the picture would be helpful.
So Cindy has a comment. Unmute yourself, Cindy, please. Okay.
Thanks, Ollie, and thanks, Jeff. Brilliant as always. I always appreciate your talks because of the clarity, and I always learn something. And thank you for invoking the Z transform, which I haven't heard of in 25 years, in about 25 years, roughly. I just dated myself. Question, I did read the Alamdari paper in 2019, and I've always wanted to ask you, do you think that time-varying elastance can arise out of, I call it stochastic, but call it what you will, opening and closing of the smaller airways over time? And whether that might manifest itself in the oscillometry frequencies that we normally measure.
It might. It has to occur. It has to include energy in the wavelength that you're using for oscillometry in order to have a significant effect. So that doesn't need to be much, but it has to be there, and it also has to be out of phase with volume. It has to be in phase with flow, which is a strange thing if it's a healthy subject. But with obstructive disease, with flow limitation, it is in phase with flow. And so that it's a very profound effect in COPD, where you do get elastic variation and it's due to flow limitation, which is due to collapse of airways, small, maybe even some more larger ones in the more severe COPD. And so I do think, yes, it does affect the measurements, but I can't be 100% certain because it depends on the amount of energy that's contaminating the forced oscillation range that is varying. That matters, and that's not a lot. And we do our very best to eliminate that when we're doing FOT.
You said that that's been modeled already. Is it published somewhere that I could go and read in my own time and digest?
Well, it's hidden in a sentence in the Alamdari paper where he varied the phase.
Didn't read it carefully.
It's very small with no figure attached. So yeah.
Okay. Thank you.
Just a short remark. So Raffaele Dell'Arca would be very thankful for the new interpretation of his data because
I don't think so.
His interpretation. Thank you very much. Jeff Fredberg. Jeff, please.
Hi. Yeah. So I'm trying to understand this phenomenon. If you have a system that's elastic but time varying elasticity, there's no possibility for any energy dissipation. So in principle, the resistance should always be zero if it's purely an elastic system. But on the other hand, if the elastance is time varying, I can imagine how there's going to be, if you look at flow volume loops or flow pressure loops, there's going to be a phase lag that's induced by that time varying elasticity. They won't be totally in phase. So it seems to be that this resistance is kind of a pseudo resistance. It's kind of an artifact of how we measure. Is that a correct interpretation?
I think there's something very deep in that question, and it's troubled me where the fundamental mechanism in the physiology might be, or whether it's not in the physiology at all. It's simply in how we measure it, and we measure it trying to assume that things are stationary, but they're not. And so there's an error involved in our analysis of impedance because it assumes linear stationarity, which isn't the case. But then again, this transform and simulations that try to eliminate that effect seem to reproduce the time varying behavior.
Right.
So I'm still puzzled by that very question, that it's elastic, yet it's appearing as a dissipative phenomenon.
So it's some kind of a pseudo resistance, but whatever it is, it could, if you're right, it could show up in the data. You measure it, right? So it's going to be there. So you'd have to take it into account somehow if it's Yeah.
I just
Good.
don't want to scare too many people because I think oscillometry is safe, but we haven't really proven that. But I do believe ventilatory mechanics is not safe on a ventilator. So elastance, compliance, and resistance measured with a ventilator is in trouble for this.
Zoli, I wonder if you could take one more question or give one more comment, and then we'll move on because we're accumulating a time deficit, and I want to make sure that you have time to give your presentation and the ones that follow.
At the expense of my presentation length, I would put a comment or a question to Jeff and Jeffrey. So it makes me think if we can detach the viscous part of the viscoelastic unit, because there is a famous structural damping hypothesis which connects inherently the two things. So you can't separate the elastic phase of this complex unit.
Right, right. Yeah, I don't know the answer to that, but I think that this this paper that Jeff referred to, he wasn't really talking about constant phase models or structural damping. It was just purely a time varying elasticity. So just trying to get at what is this resistance in a system that has no dissipation? It's got to be some kind of a artifact of how we're extracting the parameters, and it's an induced phase lag, but there's no energy dissipation. You're right. If you did this in a constant phase model, it gets even more complicated still, and I don't know the answer. I don't know.
Yeah,
I think Jeff is right.
I won't belabor the point because there's a longer discussion there, but we needed the constant phase model for this to work from a nonlinearity.
Right.
So it is tied, but it is complicated.
Right.
So,
okay, so the other questions could be maybe answered offline. I know there were more questions in the chat, and I apologize for not letting you have your say, but I will give the screen over to Zoli for his talk, which will be entitled Respiratory Impedance, Frequency or Time Approach.
Can you see my screen properly?
Yes, we can. We see the main slide and the upcoming slide, but it will do.
Oh, just the other way around. Let me try to change them. Is it better?
Perfect.
Okay. So I'm recalling an earlier line of thought about how we ended in the conventional oscillometry and neglected in the meantime the interbed changes. So Art Du Bois was top there, and this indicates that the first measurements were carried out with sinusoidal oscillations. And then as time passed and computer facilities were more available, multiple frequency measurements were introduced. It was basically in 1975. A short-lived random noise was followed by the impulse train in a year's time, which were not going to survive because pseudo-random took over. But ironically, the impulse oscillometry system bifurcated from this mainstream technological line and gave rise its own life. While these multiple frequency measurements got finer and finer, some studies which looked into the fast changes, the temporal changes, specifically the intra-breath changes of respiratory impedance, were not followed by much interest. In fact, not long ago, I found René Palin's paper in French in 1971, long before the first multiple frequency measurements were initiated. And some 8 years later, a commercial device, a Siemens device using a single 10 Hertz oscillations was put into operation, which was studied in the different investigations by other people. And probably the first turn into the practical field was initiated by the Lacker's paper in 2004, where the famous intrabat change of reactance which just Jeff Maxim presented, was published. And that gave rise further steps in the intrabat measurements. These diverse signal types can be marked by the first users of this technique, but it is not a comprehensive assessment at all. So let me show you the first paper which demonstrated the intrabat variations of resistance. This was using basically a transfer impedance measurement. Therefore, the resonance frequency was low, 345 Hertz, and that gave possibility to a very rudimentary follow-up of the resistance changes within the breath. In this paper, the inspiratory part of resistance was modeled with a so-called Rohrer nonlinearity, and also some volume dependence, which affected inversely the resistance values. And different fittings were achieved for the inspiratory and the expiratory parts. Another interesting and not terribly often cited paper also demonstrated intrabat changes with the 10 Hertz impedance. It was a little bit funny and unusual presentation of impedance in a polar coordinate system, displaying the magnitude of impedance and the phase angle. And we do see intrabat loops in this coordinate system. Quite small for normal people, but for asthmatics, it's a higher deviation. Also, small inspiratory expiratory maneuvers were shown to cover a wide range of resistance and different dependencies in slightly, moderately, and massively obstructed patients. Another breakthrough paper was published on model experiments and some human measurements, both showing that in model measurements, slow oscillation frequency can't follow the changes of impedance during tidal breathing, whereas if you speed up the measurement frequency, the oscillometric frequency, you can follow these changes in resistance in a non-linear resistor system. And here you can see that inspiration is dominated by a flow-dependent pattern, but also a decrease with volume, which reverses in the expiratory phase. And the principle of measuring a nonlinear system in small amplitude oscillations and responses, you can map sort of piecewise linear way the impedance of the respiratory system. So we made a simulation study in which the input flow was the sum of either simulated or recorded spirograms, plus oscillometric flow components. And we describe the resistive part here as a constant as the rotor flow-dependent resistor part, plus a volume-dependent term in resistance, plus we added elastance, which varied, of course, the elastic pressure varied with lung volume from FRC to the top of the inspiration, and also included the nonlinearity in this formulation. So if I stop right at the beginning, here is the slightly variable breathing pattern, spontaneous pattern plus oscillometric signal, a composite signal consisting of 5 to 37 hertz relative primes. And if we have a very narrow bandwidth around 11 hertz, we just have a long-term fluctuation in resistance and reactance, but it does not follow the breathing pattern. If we go a little bit further up and involve in the bandwidth of band passing the signals, the breathing frequencies, side lobes carrying the modulation information, we see a roughly sinusoidal change breath by breath in resistance and reactance. Stopping and allowing a further harmonic will display very marked changes in the intra-breath cause of resistance, while the elastic properties, the reactance, don't change too differently from the sinusoidal. But slowly involving more and more side lobes and more information on the modulation, after a certain bandwidth, the pattern would not change, delineating and expiratory and inspiratory resistance values, an inspiratory peak and an expiratory peak. And this won't change too much for long, where suddenly a component from the same oscillometric signal, the 13 hertz component, is interfering with the 11 hertz tracking frequency. So then we add some interference from neighboring signal components. In short, if we simplify the situation and plot the 11 hertz oscillatory component, the side lobes carrying the volume-dependent information, which then has a double frequency modulation coming from the biphasic change in resistance. And the volume-dependent changes disappear, but the flow-dependent changes stay on. So many information is covered in this bandwidth until an external disturbance is not ruining the whole picture.
Zoli, you're at the 10-minute mark.
Okay, so in short, while these studies the previous studies were conducted, much attention was paid for the different frequency dependence, like the high frequency part, which was a short-lived but very, how to say, picturesque type of oscillometry, the low frequency oscillometry with all the pains together with it, and the medium frequency standard range. So just a final remark. In a multi-center study, we collected intra-breath data measured at 10 hertz oscillometric frequency in healthy asthmatic, cystic fibrosis, ILD patient groups, and mixed patient groups, and a group of newborns. And we can see that the change, intra-breath change in resistance as expressed, the percentage of the end expiratory impedance magnitude is about 20%. The changes are milder in reactance, but they show different patterns depending on the patient groups. And the peak-to-peak changes of resistance amount up to 60–70% of the impedance magnitude, and some 30–40% in the reactance. These changes are relatively higher in newborns because of the nasal pathway. So overall, I would like just to emphasize that these changes, with very wide ranges, of course, between the maximum and minimum values, but are significant enough to think about the possibility of meeting the conventional multi-frequency measurements with the Interbreath technology. Two examples. This is a very, very nice ornamental part of impulse oscillometry. These values can't be used, are not used in the evaluation. They just depict the nature of interbreath changes. The values may not be terribly reliable, but they inspire the reader and the user to look for the degree and the nature of the interbreath changes. And that's all. Thank you very much for your attention.
Zoli, thank you for an inspiring talk that reminds us how we can build upon old work by revisiting it. So it was really a case of back to the future. And Jeff, you're the perfect person to lead on this discussion, so please go ahead.
Thanks, Ron. Thanks, Zoli. Very, very interesting stuff. Nice to see the spectral analysis and how the side lobes were adding the information to the interbreath data. So it looked as though between the different diseases in your table, I noticed COPD wasn't one of the diseases, that resistance, the delta R, wasn't that different between diseases, but the delta X was. And it went by too fast for me to look at the meaning and try to figure out why delta X would be large in some and small in others. COPD, I can kind of think delta X should be large because of expiratory flow limitation changing during inspiration. But can you speak to any insights as to what you're seeing with the delta X's in some of those other cases, ILD, CF?
Yeah, I'm happy. So these data came from the laboratories of Chang Wei, Ron, and Stuart Gottfried, mixed populations. One of the above friends of mine has not completed the COPD cohort, so I couldn't separate a COPD group, which would probably more clear-cut specify these delta R and delta X issues. But in advance, I can tell you that what we understand in delta X is different from the Delaca's mean inspiratory minus mean expiratory. It is the change between end expiration and end inspiration. So that is the inspiratory part, which is basically characterized by this value. And this change is basically negative because during inspiration, a very heterogeneous periphery is sort of normalizing a bit by the end of the inspiration. It is just the opposite in the case of interstitial pulmonary fibrosis, where the heterogeneity is not very dominant. On the contrary, it is a restrictive and relatively homogeneous disease. So the change in reactance between end expiratory and end inspiratory points is just the opposite. And it is the other side of the normal population. So it is a very distinct feature, which is otherwise hidden in this spectral oscillometry.
Yeah, that's very exciting because that's been one of the weaknesses in oscillometry is being useful in restrictive disease. It hasn't been too useful to date, but with the interbreath, it seems like it has great potential. Awesome. Are there questions from the floor? I notice you switched to 11 hertz. The recommended frequencies vary between children and adults for interbreath.
Yeah, so the one issue is the minimum temporal resolution of the oscillometric signal. So we need to have sufficient cycles within the total breath or the inspiratory and expiratory phases to have a chance to pick up the zero flow values like end expiration and inspiration. That's one thing. So 11 hertz is a different story. So we tried to extract intrabreath information from composite oscillometric measurements, and 11 hertz was found to be the closest to the 10 hertz measurement, which we normally use in children and in the adults. In infants, we use 16 hertz because they breathe faster. But I think that this is a compromise between the sufficient number of samples within a breathing cycle and the possibly lowest frequency with which we can attain this, because we don't want to follow the changes in inertance at 30, 40 hertz sampling frequency rather than the elastic properties.
Right.
Well, I'm wondering, in the interest of time, if we can move on. Thank you both, Zoli and Jeff. That was great. Julie and Alan, I want to thank you very much for bringing to my attention our next speaker, Catherine Sukahara from the University of Pennsylvania. Catherine is going to be talking to us about the design and implementation of a multi-center protocol to obtain oscillometry data in preterm children. And it's really a great pleasure to introduce Shannon Simpson, all the way from Western Australia. Shannon, I hope you're on the call, and welcome. Shannon, as you all know well, will be leading off the discussion. Following it, I will not end the meeting at 9 o'clock. We will stay on for another 10 minutes for anybody who's interested to hear out the discussion that's going to ensue. So please, Catherine, welcome, and take over the screen.
Okay, thanks so much. Is this, let's see. This is showing up okay?
Beautiful.
All right, perfect. Thanks so much. So I'm Katie Sukahara. I'm a pediatric pulmonary fellow at the Children's Hospital of Philadelphia. So I'll be talking about the design and implementation of a multi-center protocol to obtain oscillometry data in preterm children on behalf of our group. So why are we interested in the lung function of preterm children? So prematurity is associated with bronchopulmonary dysplasia. So this is a pulmonary disease that is diagnosed in the neonatal period. And we'd really like to understand better what the long-term consequences of this are. So for everyone, lung function declines over time. And so we want to know, if these children start with lung disease early on in life, how does that drive their adult disease? And to do this, objective measures of lung function are critical to assess these respiratory outcomes. There are some challenges in doing pulmonary function testing in this cohort of preterm children. So there's high rates of neurodevelopmental impairment among extremely low gestational age neonates, also termed LGANs. And this is defined as less than 29 weeks gestational age. So because of this, forced maneuvers such as spirometry might be difficult in this population. Impulse oscillometry, as you all know, has the advantage of being performed during tidal breathing and has been done in this population in several single center studies. Also, Bjorn et al. Found higher success rates for iOS than for spirometry among 6-year-old children born extremely preterm. But to our knowledge, there are no prior multi-center studies of iOS in this LGANs population. So our objective was to develop and assess the feasibility of a multi-center iOS study in the LGANs population. At the outset, we were aiming for about an 80% yield of research quality data, which I felt was a reasonable goal in this population, given the specific challenges. We had a really nice opportunity to do so based on the hybrid outcome study that was ongoing. So this is the hydrocortisone for bronchopulmonary dysplasia, respiratory and developmental outcome study. This was part of a study that had initially recruited patients who were infants born at less than 30 weeks and were intubated at 14 to 28 days of life. It was a multi-center randomized controlled trial where these infants were randomized to either a course of hydrocortisone or a placebo. And across all centers, there was a recruitment of about 800 patients. There was a scheduled follow-up point at 22 to 26 months corrected age, where they were assessed for moderate or severe neurodevelopmental impairment. And then as part of this hybrid outcome study, an additional follow-up point was defined at 5 to 6 years corrected age. At this point, they'd undergo developmental assessment, respiratory questionnaire, and a 6-minute walk test. And this 5 to 6 year age point was chosen because this would be about when they would be ready to go to school, so school age. This last follow-up point provided a nice opportunity to collect additional objective data via the addition of iOS. So our methods for this study were, for the study cohort, we were using children who are already enrolled in the hybrid outcome study as described. That hybrid outcome study was done at 19 centers. For the iOS portion, we decided to do a subset of those centers. So 5 of the centers would do the iOS at the last follow-up. The device we're using is the BiAir iOS system, which is undergoing daily calibration, verification via test resistor and impedance, and then cheek support and nasal occlusion is provided by study staff. At the time, the protocol and the quality control criteria were based on the Childhood Asthma Research and Education Network. So to roll out this study, a standard operating procedure was developed and disseminated to all 5 centers. And representatives from each center attended an in-person training meeting in Indianapolis, Indiana. Throughout data collection, there's been centralized review of testing data to ensure research quality criteria are being met. And prior to any data collection on the study subjects, each site submitted 5 tests for iOS certification. And we've also been holding monthly multi-center virtual meetings throughout the study. Our research quality criteria for acceptability were defined as these 5. So the first is visual observation. So we want to see a regular respiratory pattern, no leak, no cough or noise, no evidence of glottic closure. We did use coherence. We wanted coherence at 5 Hertz to be 0.6 to 0.9 and at 10 Hertz to be greater than or equal to 0.8. Each trial should have about 20 seconds of data collected or at minimum 5 breaths. R10 should be less than R5 on all trials, and we are looking for reproducibility. So at least 3 trials with an R10 within 20% of the maximum measured R10 from all the other trials meeting criteria. Just for context, the data collection for this study began in 2018. So I know there are more recent guidelines for acceptability that differ slightly. And at the time, they were based on the NIH-funded CARE network and literature available. So our metrics for assessment included feasibility, so the number of completed tests over the number of attempted tests, success, which we defined as the number of technically acceptable tests determined by that central overreading process as the number of completed tests. And then we had this metric real world success, which was, so out of the number of children that sat down to do the iOS, how many of them were producing research quality data that were technically acceptable by the overreading criteria. Our statistical analysis is straightforward at this point. We're just doing some primary analysis. And so the descriptive statistics were used to describe the demographic and clinical characteristics. Chi-squared tests and t-tests were used to compare subject groups who had either had successful research quality data or were unsuccessful or were unable to complete the iOS testing. So this slide just shows our overall study cohort characteristics, and I'll just point out a couple of things. So for gestational age, the mean was 24.94 weeks. So it's just for reference, full term would be 39 weeks, and then a standard deviation of 1.45. So there's really a significant degree of prematurity among this cohort. Similarly, the mean birth weight was only about 733 grams. And then for this population, or for this cohort, our mean days on ventilation was 48.75 days. And here's some of our preliminary results looking at the feasibility and success rate across all 5 centers. So we've had a good number of tests that were performed at each center. And again, our initial goal was around 80% for our real world success, and we are relatively close to that. Data collection is ongoing. And then we want to take a look at factors that are associated with real world success. So which of these children were able to complete and produce research quality data, and which were either unable to complete or were not able to produce high quality data. And again, I'll just highlight a few things over there on the right-hand column. I've just highlighted the p-values that are less than 0.05, which includes the days on ventilation. It also includes the second one is this GMFCS level 2 or higher. So this is a gross motor classification function system. It's a way of grading cerebral palsy. And level 2 would mean difficulty walking long distances, requiring assistance upstairs. So this group includes any patient with this level of impairment or greater. And then another point that goes along with this is that we found that muscle tone relaxing or reducing medications or injections significantly differ between the 2 groups. So in conclusion, we found that using a standard operating procedure and an in-person training session, we were able to obtain research quality iOS data in a high percentage of our study cohort, despite the unique challenges in this population. We have so far found that children requiring prolonged mechanical ventilation and with impaired motor function are less likely to successfully complete iOS. And this protocol may offer a framework for future multi-center iOS studies in complex pediatric patients. So with that, I just want to thank our group. We have Dr. Sarah DeMauro is our PI on this project, as well as the 5 study sites and our funding sources. So thank you all for listening.
Okay, thank you very, very much for that interesting talk, and sorry about the compressed time. You certainly respected the time constraints yourself. And as I said, we'll stay on as long as the discussion goes. I'll terminate the meeting when everybody is left. So Shannon, please, if you're out there, reveal yourself on the screen. Kate, you'll stop sharing your screen and we'll go back to the gallery view for the discussion.
Hi, everyone, and thanks, Katie, for a really informative talk. I'm just wondering if anyone has any questions first up. Charlie, hello.
Hey, really interesting study. So I was deeply involved with the QA/QC for the CAMP study, particularly in the first 5-10 years. And one of the things you'll learn about this is, of course, measuring spirometry, which is the primary outcome for that study. I had 8 centers, and one of the things you quickly learn is that the variation from center to center is almost solely due to the technician performing the test, because spirometry is effort dependent, et cetera. I noticed you had a fair bit of variation from center to center, and although you ascribe it to the condition of the children, I wondered to what extent it was due to the technician's enthusiasm or attention to detail from center to center. And if so, what have you targeted to address that issue?
That's certainly something that we've discussed. You know, I think one of the things that's been helpful is having these regular monthly meetings to kind of talk about different centers' approaches. I didn't present some of this data, but there is some slight differences too in terms of how many of the tests are being attempted on these children. The attempt rate is overall pretty high, but I think that too speaks to sort of this hard to quantify subjective assessment of, you know, is this child going to be successful? How many times do we attempt it? And so I think over time, you know, seeing some of the positive results from the centers who are maybe giving the children, you know, more than 10 trials or, you know, different forms of encouragement has sort of helped to increase our yields. But, you know, once we have more data, we'll be able to see if there's a better trend there.
Thank you.
Thanks, Katie. Can I just follow up on that? And how many of your centers of these 5 were routinely performing oscillometry as part of their clinical practice? Because again, that might sort of lead into these changes or this variation between centers.
Sure. I'm actually not sure. I know here at CHOP, we don't regularly do it clinically. It's mostly been a research procedure. Clement, I don't know if you want to speak to that.
I can answer that.
Okay.
Yeah, because so of the 5 centers, 2 of them were actually using it routinely in clinical practice. I also just want to expand on what Katie said. Early on, there was also, in addition to these, as we mentioned, we did the so-called certification process so that each center needed to submit 5 research quality studies, not necessarily from this patient population, but just in this age range. And also early on, Charles Clem, who was the primary respiratory therapist who did the quality control, if there were issues, we would Zoom with that center to kind of really go over those specific points that led to this study being unacceptable.
Thanks. Jeff, have you come on for a question?
Maybe a quick one. I noticed one of the rejection criteria for feasibility was R5 must be larger than R10, I mean R20. And actually in healthy adults, R5 is often below R10. Now these are children and on ventilators, and so that is an unlikely scenario to be a normal situation. But once you get to the school age children, some of the patients might actually end up with a normal value of R5 that is lower than their R20. So I don't think you want to be rejecting normal patients.
Okay, thank you. That's an interesting point. I think, and correct me if I'm wrong, but I think we were trying to base this off the asthma care network at the time, and I believe that was one of theirs as well. But we have all the raw data, so that's something we could certainly go back and look at. You know, how many of these are being rejected based on that criteria.
Just to put it in perspective, having chaired the physiology committee in care, that was over 20 years ago, and so I think that there may be tweaks that could be done. I think Charlie's comment is likely quite valid, particularly since you're doing older and above. What was their failure?
Sorry, you broke up at the end there. I think you'll have to repeat that question so that Katie can.
Sorry, I apologize. Yeah, what was the main cause when the child failed to get an acceptable minimum? Was it that they just would not cooperate? They were swallowing too much, the kind of things you'd expect with children that had neurodevelopmental problems, and maybe facial aversion, not liking holding. What led to those failures? Meaning, was it the criteria, or was it they just couldn't get the test done?
Okay. So as far as like not being able to attempt or complete, when we look back at the data, there was certainly sort of like a child behavioral component. When we look at in terms of what we determined to be a successful test, it looked like they were meeting criteria about 80 to 90% across all 5 criteria. So it was hard to sort of pinpoint one cause for, I guess, test failure.
I'll just make one comment there also. I think that different centers used different techniques for engaging the children, and that might be a source of some of the variability also. Some centers show like movies. We found at CHOP that movies sometimes distracted the kids and they would laugh or giggle, so we actually found that it was better to have the child just concentrate on their breathing. We would sort of coach them at their breathing and try and mimic their own respiratory pattern as we were coaching them, kind of like a relaxation technique. And we were not above bribery. So every child was promised a toy at the end. And that was actually a pretty good incentive for getting them to stay on the mouthpiece for 20 seconds. I just wanted to bring up one more thing, which is Cindy Thameron's question about controls. And we're actually looking at both a preterm control group and a healthy control group, but we haven't analyzed that data yet.
I was going to go ahead, Cindy.
Oh, so sorry. I just wanted to clarify. It wasn't about controls, but about biological controls, which are trying to establish that, well, first of all, to establish that your equipment doesn't drift over time, but also to enable comparability across centers, and also to characterize what the variability of your healthy population is within and between centers.
So you're talking about session to session variability.
Yeah, and yes, but biocontrols is, I guess, a much longer scheme over time that and enables you to establish equipment drift or and pick up if anything goes wrong.
Yeah, thank you.
Cindy, that's great. That was a perfect segue into the question that I'm actually going to draw out Cheng-Wei Chow to answer. Cheng-Wei has done a lot of thinking about how to keep standards up and quality control in the adult world. Now, you in the children's world have a different set of challenges in front of you, but Cheng-Wei, you've not only thought, but you've published on the topic. What would you advise the folks performing the study to look out for?
Yeah, I think the idea of doing the biological controls is actually really important. I think that is also, and also I think helps move a little bit in terms of the field of oscillometry, because I think when we initially started on these studies, we were also of the opinion, based on some of our reading, that the variability was going to be much higher. And we do biocals in our lab every 6 weeks. And what we have found over time is that the covariance is only about 8.5%. Now our healthy controls are very different from yours, because we're an adult center, and unfortunately, or fortunately, depending on how you look at it, our biological controls are based on my students and the lab staff in the PFT lab. So we are very much, our age range is very small. We don't have children, but we also don't have a lot of older adults, and we have a lot more women than we have men. We are beginning to actually do some studies with some adults who are cognitively challenged, and these will become really important in terms of the quality control. The other issue, I guess, is that of differences in the instruments, and we, for many different reasons, we only use the tremor flow, but we have several different devices. And obviously the drift or the differences between the different instruments and the different manufacturers will be really important in terms of comparison between groups.
That's a great point. And actually, we have now an IRB approved protocol to compare tremor flow with iOS in a large range of pediatric age ranges. So I think that's a crucial question. They are really very different.
So Cindy and Cheng-Wei, can I just clarify? So by biocontrols, you're talking about using not just normal controls, but you're using them periodically to ensure that the instrument doesn't have drift. So do you try and use the same person like every month or something like that? Right. Yeah, actually, we did that for another study I did before, but we haven't incorporated that into this study. I don't think they were doing that for the other like CARE and ICAS and things like that.
I know it's often done in spirometry across centers, but the recently published, well, I say recently, it's actually last year now, oscillometry standards actually do recommend that biocontrols be done as one of your QC measures. So it's worth checking out.
Yes, thank you.
Yeah, and I think maybe sort of from an implementation point of view, it might be easiest, our PFT lab does their biocontrols and calibrations every 6 weeks. And so the research staff actually have to do that. And we actually ask that the pulmonary function technologists, when they do the biocontrols, that they just add oscillometry as part of another component to them.
Hey, do you feel it's okay to use adult biocontrols, even though this is a pediatric study? Because obviously, well, first of all, the kids are going to get older, and second, it's much easier to get somebody at work here to do it than to bring our kids in.
I mean, certainly we do. So we're a pediatric laboratory and we have adult staff doing all of our biological controls. And I mean, that serves a number of purposes. I guess it's convenient and all of those things. We just have our laboratory staff do them. Additionally, I guess if your main purpose around biocontrols is about checking instrumentation, so it's more of a technical check rather than checking biocontrols over the entire range at which you're measuring your patients, then it's okay. And certainly we now, within Western Australia, we have different people move between different laboratories. So between our adult laboratories and our pediatric laboratories, and they form a biocontrol network that go around Perth every Friday afternoon and just do that. So that's something that has been implemented, and we certainly use our same controls in the pediatric centre, if that helps.
Into those days, Shannon, from Perth.
I know, right? Any final comments for Katie?
Well, may I just comment on the controls of devices, because I agree that biological controls serves a purpose, particularly if you go over a wide range of severities. Now, the problem if you have a relatively healthy little group sitting in your lab is that you're going to be down in like one corner of your possible spectrum of severity, whether that's a resistance or reactance, doesn't matter. I think to make sure that the instrument is working, you would be probably way better off having standardized phantoms, whether that's just a glass bottle or a standardized resistances or a series of those made with a pipe for inertic properties as well. That would probably serve you better in terms of qualifying that the instrument has not been drifting. Using biological controls, to me that sounds risky.
I think you should do both, Leonard, and I'm glad you mentioned that, because we actually published a follow-up to the technical standards specifying that it's important. Like, we've all been happy using 2 centimeters of water seconds per liter resistors to verify machines, but the letter actually suggests going up higher to mimic disease, and so that should be done regularly. And they serve similar purposes, but also slightly different, because there are some things that biocontrols would reveal that that a simple resistor wouldn't tell you. And as for glass bottles, I definitely have seen a few glass bottles around the place. I think the problem is that we still don't have a good standard for reactants, which I guess we talk about in the letter as well.
No, you're quite right, and probably know. I also published a couple of years ago a paper, where we compared instruments and we used both patients and glass bottles and resistors and whatnot, and they do serve different purposes, of course. But I think if you just want to know that the instrument is measuring what's supposed to measuring, you need a solid reference that you know something about, and you can never know that about a patient. But that's a different thing.
I think that's probably why it's important to use your healthy controls, so your laboratory staff rather than patients, because obviously with patients you're going to see change over time in terms of status, etc. And that's exactly what you don't want. So you want to make sure that you're really stable. You recruit stable laboratory staff that don't have asthma or any of those things, to make sure that you see that similarity over time.
Well, they don't have like a beginning cold or something. I mean, all of those things are sort of moving, and you're dealing with a variability that is much higher than any sort of standardized equipment. And Cheng Wei, she just showed that with the ongoing deterioration of a lung transplant, you will have a drift of some sort over time. Kids, they have another issue because, partly because they're growing, and that in some ways they're improving their lung function just by growing, right? At the same time, they might have a disease that is going in the opposite direction, and trying to sort out what really puts high demand on what your control is.
I guess the people will allow you to also check whether your technique is okay, which your resistor wouldn't, and it would allow you to compare between technique between centers.
That's a very good point. Yeah, no, I agree totally with you.
I guess I would just say quickly that I would encourage everyone to look at the standards, because I mean, a lot of us most of us on this call, many of us on this call, put a lot of thought into what the recommendations, and some of the topics of discussion are already discussed at length there. So I would encourage everyone to just have a look.
Agreed. Thank you, Cindy.
Yeah.
I'm going to hand back to you. Thanks for the really engaging conversation.
Okay. Shannon, thanks for coming all the way across to join us this morning, and really thank you to the whole team down involved with your study, Kate, because I shout out to Julie and Clement who've been on the call and participating. It's just wonderful to see or to hear the shared thoughts and concerns we have. It sounds like there are similar challenges we're facing across our laboratories and within our clinical populations. So if we can help think of a way forward, solve some of the issues through meetings like this, then they're serving their purpose. Also, I'd encourage you all to network. A lot of what we talked about within the chat was not addressed in the conversation. So reach out to those who you think could answer your questions, and feel free to carry on offline conversations. I apologize for the confusion on the links, and I'll be certainly more careful next week. I thought the first one was automatically canceled, but to assume is really clearly at my own risk. So I'll have a single link for next week. The fact that we've got 58 out of 72 people still online 20 minutes after, I think really serves as a thank you to all of the participants who presented and discussed today, that your topics are of keen interest and are very, very important to our ongoing projects and work. So thank you very much. I'll end the meeting now and look forward to next week, next Wednesday morning, same time, same place. Bye-bye.
Thanks, everyone.
Thank you.